Good afternoon, everyone, and welcome. I am Francesca Weeks, the Policy and Research Manager at the National Association for the Advancement of Colored People, the NAACP, and I'm happy to be moderating the National Kidney Foundation's Facebook Live on why communities of color are affected by COVID-19 more than others. I would like to introduce our panelists today, Dr. Kurt Campbell and Dr. Sylvia Rosas. Dr. Campbell is an associate professor of medicine, vice chair for diversity and inclusion, and director of the nephrology fellowship program at the Icahn School of Medicine at Mount Sinai. He is the president of the New York Society of Nephrology, a member of the directors of the NephCure Foundation, and a member of the medical advisory board of the National Kidney Foundation of Greater New York. Dr. Rosas is a nephrologist and epidemiologist at the Joslin Diabetes Center and the Beth Israel Deaconess Hospital in Boston, Massachusetts. She is the director of the Latino Kidney Clinic at Joslin Diabetes Center and is an associate professor of medicine at Harvard Medical School. Dr. Rosas is a member of the National Kidney Foundation Medical Advisory Board of the National Kidney Foundation of New England. Thank you both for joining us today in our discussion about disparities in COVID-19 care. Dr. Campbell and Dr. Rosas, it's a pleasure to have you here. And if you guys have any comments before we get started.
Oh, thanks for having us. I think you're muted.
You're muted, Dr. Rosas.
Thank you. Can you hear me?
We can hear you now.
Thank you very much for inviting us to discuss this very important topic.
Okay, so before we start our discussion today, I would like to encourage our viewers to make sure you submit your questions to our panelists in the Q&A section or in the chat section. We'll make sure we put those at the end, and we'll try to get to as many questions as possible. To submit a question, please click on the Q&A feature at the bottom of your Zoom screen, or if you're in Facebook, you can put it in the Facebook Live comments, and we'll see that as well and be able to ask those questions. We start with a discussion of the impact of CKD, or a chronic kidney disease, on communities of color. Dr. Campbell, it is my understanding that minority populations are at higher risk for kidney disease. Can you explain why that is the case?
Absolutely, and there have been some genetic factors that have been implicated in increasing the risk for kidney disease among minority populations. In particular, there's a gene encoding a protein, apolipoprotein L1, so the gene's APOL1, which is highly associated with non-diabetic kidney disease. And it's a gene mutation that's highly prevalent in patients of African descent. Certainly, there are other risk factors for kidney disease, including diabetes and obesity, which can be more prevalent in minority and populations that face socioeconomic challenges, right? And access to healthy foods and poverty in general is actually also associated with increased risk for kidney disease. So that gets into the social determinants, which clearly impact a number of chronic disorders, and has been implicated in the risk for coronavirus, right? That we'll talk about here today. But we can't discuss kidney disease in isolation from those other factors that will impact healthy living and access to a healthy lifestyle in general, which of course increase the risk of the risk factors for kidney disease, but also kidney disease itself.
Great, thank you for that. Dr. Rosas, can you explain what people can do to understand if they're at risk for kidney disease?
Sure. So as Dr. Campbell had mentioned, there are multiple risk factors for kidney disease, but the two most common diseases that are associated with kidney disease are diabetes, which is the most common cause of kidney disease in the worldwide, and also hypertension. And obviously, if you have a family history of kidney disease, then that also puts you at increased risk for kidney disease. And if you are at increased risk, then there are two important tests to do annually to see if you, at least annually, to see if you, how your kidney function is. One is a blood test that measures something called creatinine, and using your age and your gender, there's a formula that gives us how much blood is being filtered every minute by the kidney. Another important marker, so there's two tests, the blood test for creatinine, and then the second test is to measure protein in the urine. So those two tests tells us if the person already has kidney disease or has the beginnings of kidney disease or not. And testing is very important because kidney disease is an asymptomatic disease. So it doesn't hurt, you don't feel anything different, and therefore the only way to find it out is to test. And kidney disease is a preventable disease. It could be managed. You can try to slow progression of the loss in kidney function. And that's why identifying the people that have chronic kidney disease is so important.
Great, great. So I read that COVID-19 has been impacting minority communities more severely. Dr. Campbell, can you speak to the disparities in care that you have discussed in the scientific literature around COVID-19?
Absolutely, that's a very important point, and it kind of reminds me that what we're seeing with the disparate impact in minority communities is not limited to the U.S. We've seen similar data from Australia. We've seen some evidence that in the UK, patients from Black, Asian, and minority ethnic backgrounds are disproportionately affected by coronavirus. You know, and I think the reasons for this are multifactorial, and we'll certainly be discussing this. You know, the U.S. Centers for Disease Control has been keeping track of the epidemiology of COVID in several states and locales around the country. And they published a series in April really showing that disproportionately patients of African-American backgrounds were disproportionately represented in the ranks of the hospitalized group. And since then, we've seen a lot of data from different parts of the country. New York City, which is the major epicenter, which is where I work. You know, we've also seen Black and Latino patients being disproportionately affected among the hospitalized ranks, and also even more so among the patients who unfortunately pass away from coronavirus. You know, just some stats according to the New York City Department of Health, Black patients are twice as likely to die from COVID as white patients, and patients of Hispanic or Latino backgrounds are also more highly affected in terms of mortality. And, you know, similar patterns are seen in the Southeast, Louisiana. There's an interesting study in Houston that looked at patients by zip code, and you could almost see that whenever patients were in a more densely populated neighborhood or home, the risk of getting coronavirus and having a severe outcome was also higher. So as we discuss disparities, we have to, of course, consider racial and ethnic factors, but also socioeconomic ones, social determinant factors that may really impact the ability of individuals to keep themselves safe during this pandemic.
Great. That was a great answer. Thank you. Dr. Rosas, there's been data recently that the Navajo Nation is reporting more COVID-19 cases per capita than even in New York. Can you explain why that might be?
Sure. So in mid-May, the Navajo Nation Department of Health documented about 4,000 confirmed cases of COVID-19. And at that time, there were 140 deaths. If we estimate that the Navajo Nation, which is in Arizona, New Mexico, and Utah, have a population, you know, in 2010, it was about 170,000 people. So we estimate probably now more 250. That would be the current estimate. So that's why if you create the rates, it would be that in the Navajo Nation, there were 2,304 cases per 100,000 people, which in the case of New York, for example, it was only 8,800 per 100,000. And in New Jersey, it was 1,668. So there are many causes for this, and some are what we believe are social determinants, just like Dr. Kirk mentioned. In the, multiple generations live in one home, and therefore, if one person gets sick, it's very easy to make the other members of the family sick. Also, same as in other parts of our country, there's some food deserts, meaning that there's few grocery stores in a specific area. So everybody congregates around convenience stores, etc., for the purchase of food. And that can also lead to more people meeting, unable to do that social distancing. And also, we also know that in that population, about 30 to 40% of the population does not have running water. And in a disease where it's so important to be washing your hands, it becomes really challenging to keep with the CDC guidelines.
Right. Oh, great. Thank you. That was awesome information. One last question that I have from my end, and I would like to pose before we open the discussion up before the audience and relates and see how it addresses to the health disparities going on. Dr. Campbell, what are your thoughts on how knowing the symptoms, how to know when to get care, how do we talk to people about not being afraid and those different things?
No, absolutely. I mean, I think recognizing the symptoms associated with COVID, I mean, that's really crucial. More than one center now has presented data showing that when patients are hospitalized and you sort of control for differences in risk factors and so on, the outcomes seem to be pretty similar by race, right? So in-hospital care seems to be equitable during the pandemic, and that's somewhat of good news, right? In the sense that patients have access to care and they can get the appropriate care. They have a good chance of not being disadvantaged, right? In terms of medical outcomes. So recognizing what the symptoms are, having a primary care physician. It was amazing during the pandemic how many folks did not have a doctor, right? Who they could contact and say, hey, I'm not feeling well. So I think really establishing that line of care, knowing that you can go to the emergency room if you're moderately or severely ill, if you're short of breath, do not stay home, for example. The emergency rooms right now are actually pretty quiet. Probably too many people are staying away. But I think individuals really have to be assertive about accessing care, right? And understanding the disproportionate risk that's associated with getting COVID and mortality associated with it would also be important. Something that comes up a lot, patients who are uninsured, undocumented, but fortunately in certainly most of the states in the US, there are safeguards and safety net healthcare centers that patients can go to in order to get adequate care.
Great. And same for you, Dr. Rosas. Can you give us a little bit more about the symptoms or just a little bit more feedback from your end on kidney disease?
Sure. So first of all, I wanted to just highlight that COVID-19 will be a threat for a while until there's a medication that can treat it or until there's a vaccine. This will stay with us, and therefore we need to follow the guidelines provided by the CDC, our local, state, and federal government to try to slow the spread of the virus. I also wanted to highlight that some of our viewers might be patients with chronic kidney disease, and they might want to know some of the data on what happens if patients with chronic kidney disease, how the virus affects the kidney. And the initial reports from China were a little bit more grave. At the time, they mentioned that 5% of the patients would develop acute kidney injury, but of those that required dialysis, which was more than a third, there was a 90% mortality. If we look at more recent data from the US, which is actually also from New York, they looked at 13 hospitals, and sure, there was a significant amount of acute kidney injury, 37%, and there was also a very severe, a third of those were severe chronic kidney disease. But the mortality was not as high as that reported in China, but it was still high. We're estimating 50 to 60%. So it is important. Everybody focuses on the respiratory effects of COVID, but COVID is also having some kidney effects. And so I think that that's important to highlight. And the other thing that I think this this pandemic has given us as an opportunity to rethink how we deliver care. We're using more virtual visits. We're perhaps even some of our patients that are dialysis patients, they have noticed about the benefits of doing home dialysis rather than doing in-center dialysis. And those are all perhaps things that I'm hopeful that will stay as the pandemic subsides.
And going off of what you just said, Dr. Rosa, this is a question for you and Dr. Campbell both. Talking more about doing the in-home dialysis and getting signed up, how does that look for certain communities of color or disadvantaged communities who may not have access, who already have to go several miles out to originally go to dialysis appointments? How does that look like for them being able to have somebody come to them to do the dialysis, as well as them being able to have that protection or that prevention set up in their house, the sanitary in their house, to be able to receive that services at home?
Go ahead. Go ahead.
Go ahead, Kirk.
Yeah. No, I was gonna say that's an excellent point. In some ways, though, having the ability to get at-home dialysis during the pandemic has protected a lot of individuals. I can tell you anecdotally, we did not see among our peritoneal dialysis home hemo patients at my center a high hospitalization rate or a high infection rate from COVID. By contrast, the patients who went to dialysis units, the in-center hemodialysis patients, certainly had a lot of coronavirus diagnoses. But of course, as you mentioned, Francesca, having proper sanitary conditions and space, and from a New York City standpoint, is important. And so it is individualized, but I think that for patients who live far away from a dialysis center or those who are homebound, it's actually a better option to get a home modality implemented.
Great. Thank you. Dr. Roses?
Yes.
Do you have anything to follow up with Dr. Kirk just said?
So I've always been a proponent of home dialysis, but home dialysis is not for everybody. You have to take responsibility for your own dialysis. You have to keep track of your blood pressure. You have to do it. So there has to be a good relationship with your nephrologist. You have to be able to be a person that asks questions. If something's not going right, you feel, you have a good relationship with that dialysis nurse that's going to be there to support you, and your kidney doctor, of course. So I encourage individuals that are, I always like engineers, like my patients that are engineers or like math, etc. They make the best home dialysis patients because they give you, I don't even have to ask, they give you like a spreadsheet of their average blood pressure, their average fluid that went out, everything. So they make the visits really easy, but it can, you don't have to be an engineer to do a home dialysis. They will be able to teach you, but you have to be a person that is able to follow, strict guidance.
Right. Thank you both for those answers. Those are both great. Now what we're going to do is take a few questions from our audience. Right now I'm seeing that we have about 20 to 25 questions. We're going to try to get to as many as possible. For those questions that we may not get to, we'll try our best to be able to find some way to put some FAQs up or some way that you're able to get the answers to your questions. So first questions, and this is for either panelist. We have a question asking about the connection between sleep apnea and kidney disease. How do they impact each other, and how can we get awareness out more about how they impact each other?
You want me to go first, Kirk?
Sure, go ahead. Yeah.
Okay, so people with sleep apnea have several risk factors. They frequently have hypertension, they're frequently obese, and those two risk factors have always, have been shown to also make you lose your kidney function faster. It's actually, there have been some small studies that show that if you have sleep apnea and you wear your CPAP, your loss of kidney function is less. So it's like everything. Just because you have diabetes doesn't mean your kidneys are going to go bad. What we need is good control of your diabetes. to try to do our best, because we can only do our best. So if you have sleep apnea, the common recommendation is wear your CPAP, try to lose weight, keep your blood pressure under control. Those are things that are sort of in general. And so that's sort of the relationship. I hope that answered that question.
Anything to follow up on that, Dr. Campbell?
No, I was just gonna say, we've certainly done some surveys, and there's been some data published on the prevalence of sleep apnea in dialysis populations, right? And it's very high. I mean, I've seen rates as high as 50–60% of dialysis patients do have a degree of sleep apnea. So there definitely is a connection between kidney disease and sleep apnea and sleep disorders. So I think absolutely agree, we need to raise awareness, but as Dr. Rosa said, likely tying into the risk factors for both, right? Those chronic conditions.
Right. Great. I know in our earlier questions, we talked a lot about the Navajo Nation and African American communities. Our viewers would like to know a little bit more about the Hispanic community right now and how they're being impacted for those who have kidney disease during COVID-19.
Absolutely. So similarly, Hispanics have been affected in many ways. In part, it is because Hispanics work in sort of service industry. They are a big portion of the agricultural. And early on, there was no protection for the Hispanic worker, or any worker that worked in that industry. I think the protected gear and everything was not started in those workers, but they share very similar characteristics than we've discussed with the Navajos or the African Americans. We tend to live in densely populated areas. We tend to use public transportation. Unfortunately, minorities are overrepresented in jails, in prisons, now in the detention centers for immigration. And even though it's been said that there was not going to be any more detention, we know that that has happened. And even more importantly is the undocumented that is not seeking health care because they're worried that they will be found out and deported. So I think that's even more worrisome. So there's a lot of factors. Also, Hispanics are 3 times more likely to be uninsured. Blacks are twice as likely to be uninsured. So, if you don't work, you don't get paid. So it makes it very hard for a family that depends on your salary to, even if you're having symptoms, some would prefer to work, even though it might not be the best thing. And I also think that we haven't discussed something else, which is our social support. I think most minorities have some type of social support that's mostly their families or their places of worship, etc. And I think we're losing that social support. And we know that increased stress also may lead to changes in your immune system or make you more susceptible. Definitely a lack of social support, I think, is a very important measure in this pandemic too.
Great. Thank you. That is an awesome answer. For our next question, I have several questions. 2 or 3 questions have come in about transplant recipients and those recently who have received kidney transplant, maybe in the past 2 or 3 years. Is their susceptibility right now to contracting COVID-19? Is their immune system lower? What does that look like for them right now?
Yeah, I think that there's been a lot of debate about how to best treat patients who are on immunosuppressive drugs or patients who have gotten a transplant. I think, unfortunately, what we've seen is that those individuals are at higher risk, right, for getting coronavirus and for having severe outcomes. I think a lot of the centers in New York and several around the country have been trying to do a balance, right? I mean, you don't want patients to be off immunosuppressive drugs where there's a likelihood that they're going to reject their transplanted kidney or other solid organs. At the same time, you don't want them to make them more susceptible to viral infection. So there's been a general effort to somehow reduce the immunosuppressive dosing regimen and individualize it for specific patients to try to toe that line. I think, we'll have to wait to see in the larger published series how successful those efforts will be. Dr. Rosas, do you have anything to add on that?
Yeah, I don't think that we have enough information yet about COVID. We have seen some transplant patients in the hospital with COVID, and the treatment has been to decrease the immunosuppressant. But we have not seen like a total, everybody's coming in that got a transplant. But transplant did suffer because all living donation was stopped for a while. And a lot of patients that were, let's say, had some of the comorbidities that we early on knew about COVID, they were taking off the let's say they weren't taken, they were like deactivated. And I think that there's been a trend towards less transplants during this, at least this last 6 weeks or so. It looks like as we get more familiar with the disease and what is really happening, it seems like those numbers are now going back up in transplantation. I mean, transplanting new patients. So that's also important to mention.
Wow, great. Okay, thank you. So as for both of you all, I know you're great medical providers, great clinicians, and do great with what you do with your nephrology patients. We have a question from the audience asking, about access to care. They stated that access to care doesn't always equal quality of care. So they want to know how you all can educate or help your fellow primary care practitioners render better quality of care during this time, or even overall for our kidney disease patients. How would you guide them, or what would you even guide a patient on doing or saying to make sure that they have the right primary care clinician to help them while they have kidney disease?
Yeah, this certainly comes up a lot, and patients really need to realize that they are very empowered. And I think individuals in this audience, by getting information at the source through the NKF and other non-for-profits, I think you're certainly ahead of the curve. There are a lot of individuals who don't realize that they have options, right? If you're not happy with the care that you're getting from your primary care physician or your subspecialist, you're perfectly free to look at other options, right? Assuming there are no insurance or other constraints, I think most individuals don't fully recognize the choice that they have. It's happened many times, for example, even during the pandemic, it mattered where folks got their care. And we could see that individuals who may be living even within New York City in an area where there were sort of a lower hospital bed to population ratio, they may have been at higher risk for bad outcomes. So depending on where you were admitted or where you sought care, you may have been at a disadvantage. However, patients were transferred to other hospitals. Now that can happen. Even when hospitalized, individuals can transfer to other institutions by request, by arrangement. So I think there are always options that individuals should be fully realize that they can access.
Dr. Rosas, any feedback on that one?
Sure. I think that the best advocate for yourself, although you should try to find advocates, but you're yourself, your best advocate. So I feel like sometimes we don't advocate for ourselves. So if you call, they give you an appointment, in 2 weeks, and you say, oh, they gave me an appointment, and then you're sick for 2 weeks. Instead of saying, I'm having chest pain, instead of telling the whole story, I need to be seen right away. They wait and things like that. And we, for example, now with COVID and testing, we know that testing has been a little bit difficult in some areas, and we know that the testing isn't perfect. So if you feel sick and you got tested and you're negative and you're still getting worse, just because you're negative doesn't mean that you couldn't have it, and testing again may be an option.
Right. Great. All right. So another question we have coming from Facebook from Julia Cole. She's asked, has the pandemic created an opportunity for all of us to rethink our care for people of color?
I can tell you what I've learned. So I've learned that we can do a lot of these visits over the phone. Like I have the way I'm doing my visits is I'm asking patients to have labs drawn in centers that just do labs or somewhere close to locally, like their PCP, etc. We have a conversation just like we're having with you right now. Is sometimes in nephrology, really, we go over the labs and the symptoms frequently, and that's good enough. It might not be good for every visit, but I feel like right now I'm feeling that that part at least should continue. The problem we couldn't do it before is because there was no reimbursement for virtual visits. And therefore, that's why, it wasn't done. But I feel like it would be great if that could continue in the future. I think that is a practice that I think should continue. Because some people have limited mobility, some people have problems with transportation, and it may be easier to go locally, have their labs, and then discuss with their kidney doctor over the phone, or etc. So I do think that there are good, I don't want to say good things about the pandemic, but there are things that we can rethink on how to deliver that may make it easier for people of color to seek health. I don't know if that answers your question.
And Dr. Campbell, any feedback on that question?
Yeah, I just want to expand on what Dr. Rosa said with telemedicine. I mean, that's here to stay, right? And when we think about folks who've not gone to see a doctor because of the time constraints and office hours being during work hours and so on, when you can virtually do a visit, during a break or evening or weekend hours, I think folks are going to be implored to take advantage of the flexible access that'll be offered. In the era of social distancing, a lot of outpatient practices are expanding their hours, for example. And one thing that we've seen with the disproportionate impact of the pandemic on communities of color, we realize that, yeah, there are these social determinants that we need to address, right? And take into account more completely when we're caring for our patients, right? Because it's not simply a matter of genetic risk or chronic disease risk. It's really lifestyle, access, and other things that fortunately we can address, right, with a little more will. And I know you've seen, in the news, a lot of institutions setting up health equity institutes, and I think that's a good thing, right? I think ways that we can plug the gap in care going forward would be a positive coming out of this experience.
Great. Thank you, Dr. Campbell. So one more question. We're going to try to do 2 or 3 more questions and wrap this up. So one of the questions that came in is very, very close and near and dear to my heart. I have a grandfather who actually had polycystic fibrosis kidney disease. He was on dialysis for 5 years, along with having hypertension and diabetes, and he had sleep apnea. So one of our audience members wants to know, are the hereditary risk factors primarily related to these comorbidities such as diabetes and hypertension that lead to those early signs of kidney disease? Or is there an inherent risk of kidney disease independent of underlying comorbidity conditions?
Yeah, no, I think that there are certainly genetic disorders. There are monogenetic disorders where there's a single gene that's mutated that causes kidney disease, and polycystic kidney disease is one that comes to mind, but there are others, right? But as Dr. Rosa said earlier, predominantly the main reason patients develop chronic kidney disease and end up on dialysis, it's really diabetes and hypertension. That'll really, taken together, account for almost 80%, right, of all the cases that lead to patients requiring dialysis or a kidney transplant. So when we think about diabetes and hypertension and associated obesity and the whole lifestyle metabolic complications associated with that, we realize that some of these are modifiable, right? That with a proper dieting, exercise, kind of easy to say, right? But those healthy lifestyle choices could actually reduce the risk of developing kidney disease in patients who don't have an overarching genetic predisposition.
Great. And Dr. Rosas, any follow-up on that question?
Sure, I agree with Dr. Campbell, just because you have, and actually for polycystic kidney disease, there's ongoing trials to try to slow progression of kidney loss in patients with PKD. So the goal is to work towards slowing progression. That's our goal. We know the risk factors. We know what the problems are. Our goal is to maintain those problems the best way possible and try to gain time, make those kidneys work till the last drop.
Great, great. So Patrick would like to know what can be done to address the lack of cultural sensitivity. I know we already talked about with medical providers, but just overall in general in our community, from all social support areas, how do we address that lack of cultural sensitivity when people are providing care to kidney patients?
So I can speak for the program that I lead. So we try, when we bring our patients in, we have the endocrinologist, the diabetes educator, the nutritionist, the kidney doctor, if they need a kidney doctor. We try to do all those visits at the same time, because we know how hard it is to try to come in to see the doctor and to not get all the care provided at the same time. I think that there are, in particular in the Hispanic community, I think increasing more programs. I think there's an increasing realization that things should be included in other languages, let it be Spanish or Korean or Mandarin, etc. So I think that there is a will, but I think that to change things, it's a multi-pronged approach. We need more doctors that are minorities. We need more nurses. We need more deans. We need more everything to. It's not just the doctor or the system. We have to change the system, the education, everything. And I think if we work on multiple areas, it will be successful.
Great. Dr. Campbell, any follow-up on that question?
No, I definitely agree with what Dr. Rosa said. And I think over the last few years, there have been increasing attempts made to better educate the medical community, right, on delivering culturally sensitive care. Cultural humility is certainly something that's been discussed quite a lot recently, and more partnerships between the community and academic centers and medical practices, where patients have more of a voice in discussing priorities that they have, right, rather than the medical practitioners dictating what patients should be doing. I think that bilateral dialogue is happening more and more, and that's a good thing. So we're seeing a lot more community engagement between health centers and the surrounding communities, and that's a great model to follow.
Great. So a question that came in on Facebook from Julia Stroud. She herself is a kidney donor, and she wants to know from the reverse, not the transplant side, but actually being the donor, is she at a greater risk right now?
For COVID or in general?
She just said, should I take extra precautions? So I'm assuming right now with COVID.
Right. So as Dr. Rosas mentioned, and I'll certainly have her jump in, a lot of the living donor surgeries were put on hold during the pandemic. And, I think at the institutions I'm aware of, that they've not yet resumed. I think there's always a significant attempt to protect donors, right? I think these are, by definition, healthy individuals who, through altruism, are donating an organ to another individual who really needs it, right? So I think folks are going to be at these centers very focused on protecting the health of donors. Absolutely. If you want to comment, Dr. Rosa.
Yeah, so this person that asked the question had already donated. So I was going to say the same thing. Just the fact that she was able to donate a kidney makes her healthier than the rest
Right.
of the average American.
Yeah.
So therefore, she should follow the CDC guidelines. But right now, we don't have any data that says that living donors are at increased risk for COVID. But everybody's at risk. The risk for everybody is not zero. Everybody's at risk.
Everybody's at risk. And I'm great that you said that, Dr. Rose. Everybody's at risk. The numbers are coming out and everybody is saying, oh, it's only certain populations. Everyone is at risk and everybody needs to be preventing and protecting themselves right now. So thank you for highlighting that. So this next question is the one that's going to probably be a little bit of a longer answer, it's a little bit more in depth. I'm going to combine it because about 3 or 4 people have asked the same question. And even myself, I have the question. I'm a fellow health educator, and we educate so much about hypertension, diabetes, sleep apnea. We put so much information out in the communities, but still sometimes we don't see that uptake in people getting tested to see if they have kidney disease. We don't see people following up on the education they've been given to actually put it in action, to change their behaviors as far as eating healthy, exercising. So really in communities of color, what can we do innovative and differently to help people know about their early detection and their diagnosis? And then what else can we do to help people know about their options and resources when if they do have found to have kidney disease, such as home dialysis, because some patients may not even know that that's an option.
So, I want to start with, there are more people with chronic kidney disease than on dialysis. So dialysis is a very, very, very small fraction of people. 1 in 10 Americans has kidney disease, whether they know it or not. But only about 600,000 people are on dialysis, which is a very small fraction. So I think that there's a range there. So I think that if you have the risk factors, you should be tested. And it's the same way that if you have diabetes, you need to know your A1C. If you have family history of heart disease, people are always talking about their cholesterol. If you have a family history of chronic kidney disease, you should be talking about that creatinine and that protein in the urine in your family reunions, in your church thing, going. I know there's a lot of, there's a health ministers and a lot of, because I've worked with them, and they are always great about bringing awareness of chronic kidney disease into the community. As far as I also want to highlight the National Kidney Foundation that has several programs for chronic kidney disease and has had the KEEP program for many years. I want to say at least more than 10. So if you see a KEEP program next to your community, please participate. The National Kidney Foundation also has a great website that if you're diagnosed with kidney disease, you can learn a little bit more about it. But I also want to say, just because you have kidney disease doesn't mean that everybody's going to progress. You can still halt progression and have a significant and good life without ending up on dialysis. So I think that those are important definitions or important statements to make.
Right. And Dr. Campbell, how about yourself? Can you just tell us a little bit more about the communities of color? Like, how do we get more people out to get tested and make sure to see if they're diagnosed and get them on the right behaviors to start a different lifestyle?
Yeah, I mean, I think, especially around kidney disease, it's sort of like a silent killer, right? Patients can have significantly decreased kidney function and be completely asymptomatic, right? So that's sort of the danger in this. And I think raising awareness and really understanding, as Dr. Rosas mentioned, what the risk factors are for kidney disease and the associated conditions, I think should really spur everybody to get their kidney function checked. KEEP program is a great one. The National Kidney Foundation, again, national organization with a lot of great resources and information on the website, right? So, folks need to really educate themselves and their friends and family members, and really is a grassroots community-based approach would be good to raising awareness. I really think empowering patients, not necessarily waiting for the medical establishment to impart the knowledge, but going after it yourself, right? I think that's one of the benefits of the digital age, right? Information is literally at the fingertips of everyone who seeks it out.
Mm. Great. That's great information. Thank you, Dr. Campbell. One more question from Frances Ashe Goins. And she says she's heard that a lot of patients, particularly in the Florida area, have stopped going to get their dialysis because of COVID-19, because of the fear that there's not enough prevention measures being put up or protections for them, especially with them being an older population being at risk. What education or what is being done for these older populations who are already at risk for COVID-19, but also is very critical for their life that they go to their dialysis appointments?
Yeah, unfortunately, that's something that we saw as well in our region, that there were patients who were afraid to go to the in-center hemodialysis units. And unfortunately, in a pandemic where you have significant community spread, dialysis units were not immune. And there were many units that had a lot of COVID positive patients, but the units adjusted, right? They had COVID positive shifts and COVID negative shifts. And so there was a major attempt led by the regional dialysis organization leadership to really cohort patients and isolate those who had COVID from those who did not. So I think patients really should have that, it's certainly appropriate to be worried and take precautions, but again, it's good to discuss with your dialysis center what precautions they're taking to protect you, right? And I think folks would be more reassured if they heard a sensible plan for protecting themselves and how the staff will be protected as well. And there's some really rigorous plans in place that were largely successful. I think dialysis patients, for an unclear reason, actually did not, at least in our center, require as many ICU admissions or ventilator use as non-dialysis patients. So it was sort of interesting. And that's something that we're still trying to fully understand. But I think communication, asking questions, understanding what the safety protocols are should be quite reassuring.
Great. And Dr. Roses, how about Massachusetts? Are they seeing any dialysis patients not go to their care because of COVID-19?
I haven't seen that, but I have seen dialysis patients get COVID. And same in Massachusetts, there's been dialysis centers that are COVID positive. So if we have a COVID positive patient, we no longer keep them in our unit. They go somewhere else until they're negative. Then they come back to us. So that has happened. It does take a little bit longer for our dialysis patients, for some of our dialysis patients, to clear the virus. So sometimes they are in the other unit. I had a patient maybe over 2 months that was there until he was able to clear the virus. So yeah, our dialysis patients are definitely at risk. They always should wear a mask when they come to dialysis. They're being monitored for fevers, etc. But we're finding out that, yeah, some develop fever, but some just have fatigue. They feel very tired, and that may be their only symptom. So that's why I always say, like, you have to know yourself. You know what you feel, and if you're not feeling right and it doesn't go away, and if you have other risk factors, if you were next to a person that was COVID positive, there has to be some risk factor, then you should be tested.
Great. All right. I've said last question several times, but I promise this time, this is the last questions. There's really good questions that you guys put in here, and I just make sure you get the education you need before we get off today. So we have a kidney patient that says that they live in a household with 10 other people. And most of those 10 people are essential workers and have to go to work every day. They want to know, how do they protect themselves, because, they are being exposed to 10 people, and those 10 people are being exposed to several other people every day and coming back home. How can they protect themselves?
Let's see what Dr. Campbell has to say.
Well, this sounds like New York City, right? That's the reality of it too. But we've seen this a lot, and I think at our hospital as well, understanding that the staff members often live in small apartments, our institution actually put out a lot of guidelines on how you can protect yourself, from COVID when you live in a household with individuals who may develop COVID or be at risk for COVID. And I think, it's the similar things you see being advised with adequate hand washing. I think folks coming in off the street literally need to have a great protocol for changing clothes when they enter and washing. The good thing about the virus, we know with soap and proper bathing, hand washing, it will get off the body, with at least 60% alcohol based hand sanitizer, it will be killed. With distancing, whether it's 6 or more feet distancing, it cannot travel. So I think as best folks can do with proper hand washing, bathing, I think if possible, if an individual in the household develops COVID, if they have their own bathroom, that's also better, or significant cleaning after use. Those are the things that are quite important. And sometimes masks are needed in certain larger households when folks are interacting with each other. But these are all precautions that have been advocated by the public health authorities.
Yeah, I agree. So I was taking care of COVID positive people and other people. I was on service the last 2 weeks. And basically I came home, I took a shower, I left my scrubs at work to be clean. I changed, I have my commuter clothes. When I came in, I took that off. So basically this person has to make house rules. When you come from outside, you change your clothes, that all needs to be washed. This person that comes needs to take a shower, washing their hair every day, because they have to get that soap all over to kill that virus. And in reality, I think that if that person has significant risk factors, let's say, I don't know, the more risk factors you have, the more cautious you have to be. It could get to the point where they have their own plate, their own cup. I don't know how sick this person is, but you say, this blue plate is my plate, this is my glass, and don't touch it, basically. and sort of make rules like that. The light switches need to be clean, the handles need to be clean, and it needs to be done a couple times. I mean, if this has 10 people are coming in and out, it needs to be done several times a day.
Right. Dr. Rose, you just said something very important. Growing up, my grandmother used to always make us wipe down the light switches and the handle on the refrigerator door. And I never understood why we do that. Now I value that because I do that 5 times a day now.
Absolutely.
Don't realize how many things you touch in a day and how many people in your house touch the same thing and or may not have washed their hands as well as they should have. So just saying those simple things of behaviors of getting into is going to be a lifestyle change that we all have to get used to.
Mm-hmm.
So again, Dr. Campbell, Dr. Roses, we thank you so much for being with us today. You gave so much valuable information, and we're going to take this and not only hear it, but we're actually going to be doers of what we heard today and be able to spread this information and actually get active in our communities of color, really take heed to this advice about getting tested, making sure that we are changing our lifestyles, eating healthy, exercising, and know whether or not we have this in our families or not genetically and whether or not we need to be tested. Again, for the viewers, if you had questions and we did not get to them, the National Kidney Foundation did take down every question that was submitted today via Facebook or Zoom, and they will make sure within the next few days they take the time to get back with you. As well as if you have more questions for Dr. Campbell and Dr. Roses, you can also send those to the National Kidney Foundation. They'll be able to connect you to the wonderful panelists that we have today and be able to get the answer to additional questions that you have. Again, this is the National Kidney Foundation's Why Communities of Color Are Affected by COVID-19 More Than Others presentation today. Feel free to share this presentation. It'll be on Facebook, on the Facebook Live, on the National Kidney Foundation's page. Also check out their Twitter account and check out their Instagram account, and make sure you share this as much as possible with communities of color or just everyone out there, because everybody needs this valuable information. Again, we thank you all for viewing and have a wonderful, wonderful Thursday.
Great, thank you.
Thank you.